please start the recording if you haven't already.
I've restarted the recording. Robin, you can begin.
Okay, good morning, everybody, and welcome to today's webinar on how the U.S. Department of Health and Human Services plans to enhance evaluation capacity under the Evidence Act. We're very excited to have all of you join us today. This is being sponsored by the American Evaluation Association Research Technology and Development Evaluation Topic Interest Group. And we are beginning, this is the second of a webinar series that we're going to be hosting this year. We have upcoming webinars. The next one in June, date to be announced, will be on diversity approach for research evaluation, sponsored by the University of Sussex. So look out for our email announcement of the details. And so we're very pleased today to have two guest speakers. Dr. Amanda Cash, Acting Director of the Division of Evidence Evaluation and Data Policy in the HHS Office of the Assistant Secretary for Planning and Evaluation. And she's going to provide an overview of the Evidence Act at HHS. And then we have Dr. Aja Vadave, who is the Health Science Policy Analyst at the Office of Evaluation, Performance and Reporting, and the Division of Program Coordination, Planning, and Strategic Initiatives in the Office of the Director of NIH. That's a long title there, but he will be talking about NIH's approach to strengthening evidence building under the Evidence Act. So the format for today is that each speaker will talk for about 15 or 20 minutes. I'll be asking for 1 or 2 questions after that per talk, and then we'll open it up to a broader discussion. We have an hour today, so I want to begin by welcoming Amanda. And her portfolio includes research evaluation methodologies that are appropriate for complex federal programs. She co-leads the Federal Task Force for Combating Antibiotic-Resistant Bacteria, and her office is coordinating implementation of the Evidence Act, so she's the perfect person to give this overview of what HHS is doing. She's an epidemiologist by training, but she now works primarily on evaluation, evidence-based policymaking, and data policy issues. So let me welcome Amanda. Thank you, Amanda.
Thanks, Robin. Okay, so I think I can go ahead and get started. As Robin noted, I'm going to give an overview of the Act and give you a little bit of flavor for how we're doing this at HHS. And then I'm going to turn it over to my colleague at NIH, Dr. Ajay Wadaway, and he will tell us what they're doing at NIH and how we're working together. Okay, next slide. So again, an overview of the Act. I'm going to talk a little bit also about OMB's implementation timeline and then kind of what we're doing. Next slide. So if you don't know, the Foundations for Evidence-Based Policymaking Act of 2018 was based on the Commission for Evidence-Based Policymaking's report, The Promise of Evidence-Based Policymaking. There were, I think, about 22 recommendations in that report, and the Evidence Act, as we like to call it, is actually the first piece of statute, or the first piece of law that codified 11 of those 22 recommendations. And the goal of that commission was to basically conduct a study to determine how the federal government could use its administrative data more effectively and efficiently for developing evidence for decision making. Next slide. Josh? There we go, great, thanks. The goals of the Evidence Act are to improve decision-making for federal programs and also for policy development. If you read the Act, which I have many times, what you can glean from it is that it's really pushing the federal government to be more transparent and have a question-driven approach to developing and using evidence for decision-making. It is telling us that we need to have a systematic and efficient way to create and use a rigorous evidence for decision making, and that it's also really pushing us to be more transparent and provide open data for other purposes, for in theory, using and developing evidence outside of the federal government with federal government data. Next slide. So why does it matter to us in the federal government, and why does it matter to you? It builds on longstanding principles underlying federal policies and infrastructure. It really does kind of if you look back at the journey of transparency of information and data in the federal government, this act is actually really sweeping in what it's telling us to do in terms of transparency, as well as ensuring that we use evidence to make decisions in the federal government. It creates this new paradigm for departments and agencies to rethink how they develop and use evidence. And it really pushes us, both from OMB as well as the intent of the Act and the Commission, to have heavier collaboration and coordination across the multiple functions within agencies and departments by creating 3 key officials. And it also tells us in the federal government that we really need to be more strategic and, again, transparent about how we develop evidence by telling the public and determining what our priorities are for developing and using evidence for decision making. It also elevates program evaluation as a key agency function. There are other statutes that govern different communities, such as performance or statistical functions. This is sort of the program evaluation statute. And again, definitely requires more transparency about what our priorities are and what our questions are. Next slide, please. So what's in the Act? There are 4 titles, and the first title is really sort of about the evaluation function. It's requiring us to do in the federal government evidence building plans, what OMB calls them learning agendas. It's requiring us to do these, which is a 4-year plan that outlines what priority questions each of us are determining for evidence building or evaluation. It requires us to do annual evaluation plans, which sort of say, okay, on an annual basis, how are you going to implement this 4-year evidence building plan? And then it also requires us to do a capacity assessment every 4 years of our evaluation and evidence building enterprise. Title II, it is really forcing us to be more open and transparent with our data, not just information, but also data. It requires us to be, to have our data open by default, if you will. There's some, we're still figuring out what that means. It requires us to have a data inventory at a department level. And then that is, in theory, supposed to roll up into a federal data catalog that GSA will manage. GSA is the General Services Administration, and it's also part of the federal government. And then Title III really codifies the Confidential Information Protection and Statistical Efficiency Act, which governs statistical agencies and units across the federal government, of which there are not that many. There are 13 statistical agencies across the federal government. And then it also gives a new authority to statistical agencies and units called the presumption of accessibility, which basically says, well, actually, I'll talk about that a little bit more. And then Title IV, this is my favorite part, that says no funding. You have to do all of this with existing appropriations, and you've got to do it with what you have. So, we're doing the best that we can, I think, in the federal government to implement this. As many of you know, HHS is one of the key agencies responding to the COVID-19 pandemic, and so a lot of our efforts have been taken away from implementing this and also put towards responding to the pandemic. But I'm here to talk to you today to tell you about what we are still doing. Next slide. So the second thing that a lot of people have talked about is the 3 new positions, the key officials that were created by the Act. The evaluation officer is one of the positions, and that position for us in the Department of Health and Human Services is the Assistant Secretary for Planning and Evaluation. And right now we don't have a an ASPE, as we like to call them, an assistant secretary. So our acting ASPE is Brenda Destro. Our chief data officer is going to sit in the office of the chief information officer, and right now we don't have a chief data officer that has been determined, but we are in the process of figuring that out. And so our interim chief data officer is the CIO, and his name is Jose Arrieta. And then our statistical official per the statute is the director of the National Center for Health Statistics, which sits within CDC. The director of NCHS is Brian Moyer, and NCHS is the only statistical agency at HHS. We have one unit that sits within the Substance Abuse and Mental Health Services Administration. Next slide. Josh, maybe, are you stuck? Well, I can go ahead and start talking about what's on the next slide, which is really what our deliverables are per the Act. I mentioned the agency evidence building plan. It's a 4-year plan. And this first plan that we're doing is what's called an interim evidence building plan, because it's only for 2 years, because that 4-year plan is on the same time frame as the strategic plan, which starts with a new administration. So at HHS, what we're doing is basically making the whole the sum of its parts. So we're a large decentralized agency that's very federated at Health and Human Services. And so each one of the divisions within HHS is creating their own plan with guidance and input from ASPE, my office, the Office of the Assistant Secretary for Evaluation. There we go. And ASPE is guiding kind of parameters about what goes in the evidence building plan. We're also developing our own. And those are in development right now for a 2-year interim evidence building plan. The evaluation plan, we're using the same approach, sort of the whole is the sum of its parts. And we are currently developing those evaluation plans for fiscal year 22. The capacity assessment of evaluation and evidence building function also required every 4 years. Also, we're doing a 2-year interim capacity assessment. And we have just sent out our capacity assessment survey to all the different parts of HHS, and we have not gotten any results back yet from that, but we have fielded it. We've also piloted it more than one time, and we took several months to develop the instrument. Ajay was part of that process as well. So then the next requirement is not an HHS requirement, but was an OMB requirement. And OMB was required. OMB is the Office of Management and Budget, the President's Management Office and Budget Office. And the evidence team at OMB developed program evaluation, best practices, and competencies. You can find that in OMB Memorandum M2012. None of those are too terribly surprising, and I do know that they actually used what AEA has to develop those best practices and competencies, as well as many other inputs. OMB is also responsible for developing an advisory committee on the data for evidence building, and per the statute, the evaluation officer has to develop an evaluation policy for their department. We have currently drafted a policy for HHS. Many parts of HHS already have policies, evaluation policies, but we are currently in development for a policy for the entire department. Next slide. So Title II, I like to say that Title I is the sort of the culture change, and Title II is the business change. Title II really tells us that we have to make our data assets open. There are some exemptions in the law, and I'll go over those. And then it also has a lot of new requirements for the Chief Data Officer. It requires a strategic information resources and open data plan. Those are sort of two plans in one almost, as I understand it. It requires a data governance body. That's actually not in the statute. That's in the OMB guidance, but we're in development the Chief Data Officer at HHS, is developing a data governance body now. It requires a comprehensive data inventory, again, at the department level, so at the HHS level, but not at the division level. For us, our divisions are large components like the National Institutes of Health and the Food and Drug Administration and the Centers for Disease Control and Prevention. So we don't yet have guidance on Title II. We're still awaiting guidance on how to do this, as well as standards, but hopefully they're coming soon. It also requires a federal data catalog. As I mentioned, the General Services Administration is responsible for managing that federal data catalog, and then it creates a Chief Data Officer Council, where all the Chief Data Officers sit and meet. That is managed by OMB and GSA. Next slide. So what is a data asset, you might ask yourself. The law was very broad in terms of how it defined a data asset. It basically says that a data asset is a collection of data elements or data sets that may be grouped together. That sounds like a lot, you might say, because it is. So I'm going to go over what the exceptions are in the statute. Next slide. So you might look at these and think most of them look very similar to other exceptions for transparency statutes, privacy, security, intellectual property, business confidentiality, those types of things. The different one that we've sort of thought about a lot is the benefit cost analysis and what that means. Sort of what are the benefits to the public and what's the cost to the public to make every data asset open. So we're still awaiting guidance from OMB, but this is the one that we've sort of thought a lot about. In addition to that, we also are sort of wondering if in contracts or other obligation, we would potentially put things like consent forms in that type of exception or exemption. And then the OMB director also has the authority to create new exemptions for making all data assets open by default. Next slide. So Title III, again, is the codification and statute of the Confidential Information Protection and Statistical Efficiency Act. SIPC is really the statute that manages statistical agencies and units. They act a little bit differently than other parts of the federal government. A lot of the federal government produces data and statistics, but not all of the places that develop data and statistics are governed by SIPC, just the statistical agencies and units. And the big news here is the new authority given to those organizations. Like I mentioned, the presumption of accessibility for statistical agencies. Sometimes it's kind of a mouthful to say, especially first thing on Thursday morning. So at any rate, the authority is basically the presumption that any statistical agency or unit can request data of any other place in the federal government for purposes of evidence building. And what that does essentially is allow statistical agencies and units to request a lot of data that they wouldn't necessarily have access to otherwise because they now have this authority. The rule is being written by OMB for this particular authority, and we don't know exactly how the rule is going to be written, but it is being written. Next slide. So I have this slide in here because, it's sort of hard, I think, when you read the statute to really understand how these pieces necessarily hang together and why they were in the act. In part, it was because there were recommendations from the commission, but I also believe that in theory, the evidence building and evaluation plans create priorities for what data assets to prioritize and make open, and also potentially what types of federal data agencies can request through the presumption of accessibility. Those evidence building and evaluation plans are really meant to identify priority questions, data and methods for development, for evidence development and use for decision making. Again, in theory, they can identify gaps in evidence that agencies or departments want to focus their energy on. And so this is how I see it working together, the act working together. Nobody has told me this. This is sort of over months and months of studying the law, what it can mean. Next slide. So I'm going to tell you a little bit about the Office of Management and Budget's phased approach to implementation. We've gotten 2 pieces of guidance from them, the OMB memorandum in 1923, which was last summer. That really gave us information on how to develop these evidence building plans or learning agendas, the evaluation plans, the capacity assessment. They also told us about the key officials and sort of some guidelines around those key officials, and a little bit about Title II, the Open Data Act. And then we just also received, as I mentioned, the Phase 4 guidance on program evaluation standards and competencies. We have not received, we haven't received guidance yet on open data access and management or data for, well, actually we have received 1 piece of Title III guidance. So hopefully we'll be getting our Title II guidance soon from OMB. The next slide you kind of need to see, but I basically was going to show you what we look like. It's HHS's organizational chart. I think there are a lot of people here who maybe aren't part of the federal government. And so you can see where each key official sits. So the Office of the Assistant Secretary for Administration is where our Chief Information Officer sits. And again, he is the interim Chief Data Officer. And then below that, you'll see the Office of the Assistant Secretary for Planning and Evaluation. That's where our evaluation official sits, or evaluation officer, excuse me. And then again, at the National Center for Health Statistics, which sits within the Centers for Disease Control, that's where our statistical official sits. And you can see the rest of the parts of HHS and how large of an agency we are. We have a lot of components to manage. So, you know, we are in ASPE leading implementation of the Act, but we are heavily collaborating with our other key officials and our sister offices to ensure the best approach we can to implementation of the new law. Next slide. So this is just a little bit about our implementation infrastructure. We have 4 councils, 2 were existing, 2 are new. And those councils are really a way for us to coordinate with all of the different parts of HHS, as well as the 3 key officials, and as well as disseminate information and pull information from the different parts of HHS as we move towards implementation. And then I think we have just questions and discussion. And I think I've gone a little bit over time, so maybe I'm going to cede my questions to Ajay.
Thank you so much, Amanda, for that wonderful overview. Yes, let's move on to Ajay, who is going to be presenting approach for strengthening evidence building capacity at the NIH. And then we'll have discussion of both talks afterwards. Thank you.
Sounds good. Thanks, Amanda. Thanks, Robin. And good morning, everyone. So as these slides are coming up, I am just going to give an overview of how we grappled with the Evidence Act and how it aligned with some of our internal driving that was already occurring around evidence building and evaluation. And it just happened to be timing that it was sort of a perfect confluence of both external and internal drivers coming together that I think are going to propel NIH into sort of a new era of how we think about evidence building, how we think about evaluation, and how we can utilize it. So next slide, please. So for those of you not familiar with the NIH, and if I slip into acronym talk, I apologize, but that's the National Institutes of Health. This is our mission statement. You can see it's really about learning and understanding living systems and how that impacts health and life. And there's 2 components here that I've highlighted, which are fundamental knowledge and applying that knowledge. And the reason I highlight that is because that really ties into what part of the intent of the Evidence Act is really about. It's really about expanding the knowledge that we have and then taking that knowledge and applying it in some systematic fashion. And so our agency is really ripe for this type of mindset because it is very akin to what we do in our scientific methods. Next slide, please. Just as an overview, we had about $42 billion budget for FY 2020. more than 20,000 employees. If you include contractors and such, it's quite a bit higher than that. From that very large budgetary number, about 80% of that funding is awarded to extramural researchers, so it goes outside of NIH, and that translates to more than 50,000 grants, funding more than 300,000 individual researchers and 2,500 institutes. So this is to say that we are a fairly significant player in the biomedical research universe. Next slide, please. Just a little bit about our structure. Amanda had just talked about how we're a federation of different groups within HHS, and within NIH, we're a federation within federations. And so this is a lot of acronym soup here, but around in sort of the curve that you see there, these are the 27 institutes, centers, and offices. So if you ever hear someone slip into saying ICOs, that's what these mean. These are generally organized by either a disease area. So NCI, for instance, is the National Cancer Institute. They can be organized by body systems. So NEI is the National Eye Institute. And they can be organized in sort of scientific lanes, like the National Institute for General Medical Sciences, which looks at a lot of basic sciences. So next slide, I'm just going to highlight a little animation. So organizing that is the office of the director. Again, we're federated, there's a lot of independence, and within that OD, there's the division which I work in, which is the Division of Program Coordination, Planning, and Strategic Initiatives. And where that little yellow arrow is pointing, you can see that's the office that I sit in. We are very much a coordinating office for evaluation and performance reporting. And so when the Evidence Act came our way, it naturally was fielded to us. Next slide. So now I'm going to talk about a little bit how we thought about this act and how we thought we could actually leverage it, how we could live to the spirit of the act and also leverage it as an opportunity to grow in ways that we saw opportunity. And for those of you very familiar with evaluation and comfortable with evaluation, this is going to seem pretty familiar, I think. And I'm going to discuss this in more detail in the next slides. But in essence, we really wanted to know who our stakeholders were. Thank you. Kind of define evaluation for us as a community. And I'll mention what that is in a little bit. We wanted to scan our current environment. We really wanted to understand what's going on with our stakeholders. We wanted to develop a business case, and this isn't a mandate within the Act. It's something that we landed on as something that we felt was extraordinarily necessary to give to our leadership. And then finally, from all of that work, we were developing both the evidence building plan and evaluation outlines with final dissemination and implementation. This is being led by our office, but we also have a great internal community that is known as the NIH Planning and Evaluation Officers Community. And what that is it's representatives from all of those 27 institute centers and offices who either are participants or run offices within those 27 ICOs that have responsibility for conducting evaluations. So we have a good community infrastructure to start with. Next slide. So stakeholders, really important, right? I mean, I think this is something we commonly talk to folks about whenever they're undergoing an evaluation. You have to identify who the stakeholders are, and that comes in different flavors. It's stakeholders who you're planning to disseminate information to, that you need to get decisions from. And one of the first things we have to do was think really carefully about who for this effort were our key stakeholders. And within that, there was the P&E officers that I just mentioned, because they're largely responsible for influencing the use or being asked to utilize evaluation within their program offices. There's NIH leadership, because at the end of the day, the Evidence Act is about providing information that helps people make decisions. It's HHS, because we're part of that larger mission of HHS, and so making sure that our sister agencies and our parent agency have a good understanding of our work and how we've attained progress and the milestones we met was really important. That is the intent for standing up these efforts. Not mentioned here, but equally important are external stakeholders, whether it's the communities we serve, the physician networks we serve. This is also, in our mind, in terms of the Act, about transparency and giving people an understanding of how we approach our work, how we learn from our work, and how we share those findings to improve what we do in the future. The next step for us was coming up with an operational definition. Again, all of us who sort of worked in this space, I think we know that there can be definitional battles to wage at the beginning. There are plenty of definitions out there about evaluation. Lots of agencies have set their own definition. You can go to academia what evaluation was. We wanted to come up what we saw as just a very simplified version of what evaluation meant to us at NIH, which means at its essence, it's just a systematic, objective inquiry using different types of data, quantitative, qualitative data, to answer specific questions about programs or policies. And we want to reflect those findings against either a known baseline or a known expectation. And this was just to kind of square this and get this out of the way. We didn't want to get ourselves bogged down in the nuance of how people might view evaluation and definition. We just wanted to create a common base that we could all jump from. Next slide. So another important thing about stakeholders is it's important to talk to them. It's not enough just to identify them. So you have to go out and speak with them and get information from them to really understand what is the right path forward. And so that's what we did. We surveyed the members of the P&E community because we recognize that these are a constellation of different islands within NIH, and they all have varying levels of capacity for conducting evaluations. They have varying levels of need. They have different types of challenges based off the types of conditions they're working on, the types of data that's available to them. So to have a really informed understanding of what we might promote from an agency-wide perspective, it was really important that we got information to them. And the interviews, I will say, we found to be incredibly important. The surveys allowed us to get a lot of data in many respects because we were able to make things more quantitative, for instance, and we were, yes, able to get some qualitative data, but the interviews also provided another layer of context around that data. And I guess that's one other thing that I would mention. Data without context could have its limitations. And so trying to wrap data in as much context as possible is really useful for kind of defining a path forward that makes sense for a particular group, in this case for NIH. From that information, we felt we had a reasonable idea of what things look like. We developed an outline from some of the environmental scans that we did. And by environmental scans, I meant we looked around NIH and saw what kind of evaluations were being reported, what kind of assessments were being reported, and use all that information to sketch out what we know about the evaluation and assessment landscape at NIH today. We sent that around to our planning and evaluation officers. We sent it around to NIH leadership, and we sent it around to HHS and AFI for comment, just to say, hey, this is kind of what things are shaping up to be for us. Next slide. And so here's the new element, and this was actually a brainchild of my director, Dr. Marina Volkov. It was more than just satisfying the act, saying, for instance, we're mandated to create an evidence building plan or being asked to create an evidence building plan or an evaluation plan. Yes, we could hang on that, but if we really wanted to do what we were striving to do, which was to empower a culture of evidence building, we have to make the case to leadership on that front as well, not just that it's mandated and it's something we need to do. And that's important to think of it that way, at least from our viewpoint, because we understand that leadership, they're dealing with competing priorities. They have different budgetary priorities, different things flare up, like COVID, for instance. And so you have to, in our view, connect with them about the utility, the importance of evaluation assessments, and how that really fits into creating a strong and healthy agency. And so that's something that we've undertaken, and we're finding it very useful so far, and our leadership is responding really well to that. From the business case and from the other information that we've collected beforehand, we had developed some rough outlines already in place for an evidence building plan and an evaluation plan. Once the review of the business case has been completed by leadership, we're going to plug that in and synthesize our evidence building plan and evaluation plan to submit to ASPE. And I'll explain a little bit more about how that's shaping up for us in a moment. And then, of course, as any good public health, medical evidence, evaluation kind of effort, you want to make sure that once you reach the finish line, you're disseminating and implementing those plans. So you got to do both, right? You got to let people be aware of, hey, this is where we're going with this. And then you have to have an approach for actually implementing the recommendations described in your plan. And I'll touch on these a little bit more as well. Next slide. So just to give you an idea of where we're at, this is where we are in terms of our implementation. We are in process. That's a very vague and nebulous term, I know. But what that means for us is that the business case is currently in the hands of NIH leadership. It's already gone through a couple sets of eyes, and we've received really good feedback about what we've put together. We've created, with the help of that evaluation community, a preliminary evidence building plan and evaluation plan that we tend to flesh out once we have final sign-off on the business case. But that's moving along pretty well. And our next steps, as I said, is just to finalize the business case and then ultimately submit the evidence building plan and evaluation plans to HHS. Next slide. So even though we're still in process, there is a lot for us to share and a lot of things that we found out along the way. So for instance, barriers. I had mentioned this, the NIH evaluation community is a really varied landscape. Some have already tremendous capacity around evaluation. For others, it's still a bit of a foreign topic. They're not even sure how to engage in it and approach it. So I think that's important to assess your community, whatever size that is, and really understand how people view evidence building activities, what they think those activities might be, and what their needs are. And through engagement, it lends itself toward transparency. It lends itself to ground level communication, and it allows people then to kind of enter into this process a lot more easily because they feel part of the process. So it's really important to have that level of engagement. The other aspect is, as I mentioned, understanding that there are different priorities and concerns about evaluation and assessments. Is this an audit? Are you going to prescribe one set of parameters that has to fit everyone because the data I have is very different than the data that this person has? Those are real issues. And I think within the evaluation community, we have to recognize those differences and we have to be sensitive to those differences. And that means, as I just said, it's really important that the process that you undertake is transparent, that folks feel that they have a feedback loop that influences the direction that things are being stood up, because they want to be recognized and they need to know that whatever comes down can fit and work for them. And so again, another thing is just being sensitive to those concerns and recognizing them as real concerns. And then buy-in. So ultimately, this comes to, once you have it in place, is it just a nice document or is it something that people can get behind? So we're asking people ultimately to make choices, whether that's about hiring more evaluation staff, whether that's investing more financial resources into conducting assessments. And one of the things that we've hit on that's really important is that we need to tell better stories at NIH about evaluation. Yes, we have many reports, but these reports are often 50 pages long, and they're great from a technical perspective for those of us in the evaluation community because we want to understand the methods, we want to know the approach, we want to know the sampling. But when it comes to really engaging stakeholders and getting their buy-in, we have to produce shorter, tighter, compelling stories that show the impact and the utilization of evaluations and where it made a difference, how it changed a policy, how it changed a program design, in our case, how it changed a grant funding mechanism. Those are things that people can attach to and identify with quickly within NIH. And it was one of the things that we undertook of scouring the different stories we had and repackaging what were often very dense evaluation reports into findings that were more accessible and relatable to the various NIH stakeholders that we work with. Next slide. So some of the lessons learned, I think you've already heard it throughout my discussion so far. Communication, it's just critical, right? I mean, it's something we always talk about, I think from an evaluation perspective, but early, frequent, and informative, it just needs to have substance behind it. The other part of this is, and we benefited from this, you don't need to reinvent the wheel. We are lucky, I think, within HHS that there are a lot of sister agencies that have been down this path of evaluation for very many years. They've come up with great models for doing this, great resources for doing this. And so it's important to reach out and understand what's in the broader ecosystem than just within your particular community. Now, having said that, everybody's slightly unique, and it's very difficult just to take something and use it wholesale. You can be inspired by it, you can adapt it, but it really needs to reflect the culture and the situation that you find yourself in with your evaluation community. Organizational structure matters as well. We were able, through Amanda's office, to have a lot of guidance in terms of, well, how can we interpret this? Do we have to pick a disease condition when we're thinking about evidence building plan, for instance, say like COVID? Or can we go broader and say, we don't know what we don't know when it comes to assessments, and we recognize that folks want to understand what we're doing on opioids, what we're doing on COVID, but we also want to understand what kind of tools do we have access to really help us answer those questions? What kind of capacity do we have to answer those questions? And their guidance and support and us thinking in this way was extremely useful. So again, working with your partners and understanding where you can go is super important. And then finally, be flexible and evolve. I think we started out on one path thinking of what this would look like. As we had discussions with our internal stakeholders and our external stakeholders, we were willing to change. We were willing to adapt. We came up with a business case that we didn't need to do because we recognized the importance of doing that. And I think part of any good plan is using the data that's coming in as you're working your way through this process. And after all, that's the intent of the Evidence App, right? It's as you get more information and understand things better, you change course, or you adapt, or you amplify something that's working really well. Next slide. So where we're at for our next steps, again, just approval of the business case. We're going to finalize and disseminate the evidence building plans by synthesizing the draft. We're going to review this process with all our stakeholders. So again, continuing that communication. And then we're going to disseminate. And when I say disseminate, it's not in here, but we're going to go with tailored dissemination. The materials we might send to our evaluation community is going to be very different than the materials we send to our leadership or external stakeholders. So we're already thinking about how do we package and bundle information for different stakeholders, essentially conveying a similar message, but in a way and in a format that they can resonate with them and they can take in. Next slide. So we're going to promote its use by engaging leadership, because leadership is important. The leadership has to be engaged. It can be ground up and from top down. So that's something we're planning to do. We're going to operationalize the elements of our plan, and a lot of the elements of our current plan revolve around creating resources. So we don't have centralized evaluation resources, for instance, at NIH, and that's part of our evidence building plan, is that we're going to do that. We don't always have the best forms or methods or approaches for communicating our results across our different institute centers and offices. So we're going to create an infrastructure for doing that. And the other part of it is we want to keep a beat on things. This institute process of continuous learning is, again, something we feel is really important. You could treat this as a one-off and say, we checked the box and we did it. But if you're really trying to move a culture forward, it's important to have check-ins. And so we're going to, as we move forward, have regular assessments to find out how we're doing. Because after this first go-round, we're going to have a baseline that we feel pretty comfortable with. And now using that baseline, we're going to track to see how our changes and recommendations are influencing the culture at NIH. Next slide. So ultimately, this is all about impact, right? And we're hoping our impact helps improve our culture of organizational learning. We think we already have a good one to start with. We rely on expert opinion a lot, and that guides us. We're adding one more tool to the toolbox, if you will, to support that. We want to promote the use of evaluation best practices. As I said, people's understanding of what evaluation is and what's possible with it is varied, and so we're hoping we can kind of consolidate that knowledge. We're going to guide the creation of shared resources, as I just mentioned. And then we're hopefully going to enhance the culture of informed decision-making, right? Giving decision-makers the types of information they need to help them make the best decisions they possibly can, given the circumstances. Next slide. And that is it. So thank you very much.
Thank you so much, Ajay, for a very informative talk. We're going to open it now up to questions. And because there's 150 of you participating at this moment, I'm going to ask you to please use the chat box, and we'll read the questions, and then Amanda and Ajay can answer. And while people are writing their questions, I'm going to pose the first one to Ajay. So this is the Research, Technology, and Development TIG. And Ajay, we have a wide range of research versus program optives in HHS. Obviously, NIH is on the research spectrum. Since we try to go to long-term outcomes as much as possible in evaluation, how has the fact that NIH does research primarily impacted the way you think about what type of outcomes you're going to be able to address in the plans?
Yeah, so that is an excellent question, and it's one we've been grappling with for a bit now, and so I'm going to answer it in two ways. We have more proximal outcomes that we think we can point to. As I said, our agency is largely focused on generating knowledge in scientific publications. So we can look at things like publications, we can look at things like patents as sort of these more proximal outcomes of what we've contributed to the evidence base. But ultimately, when people look at NIH or any other agency, they want to know what types of impacts we're making downstream. How are we helping communities? How are we helping patients? What are we doing? How's our research being used in that? And so part of our plan is, in building this capacity, is to figure out how we can better tie the linkages between the information that we help generate and, say, when we hand it off to a sister agency like CDC, who's doing implementation at a community level or within certain populations, how do we make sure that connection is there? And then we can feed into the outcomes that perhaps you're getting at a public health level. So I would say it's a work in progress. We're going to look to bring folks from different parts of HHS together to help us with that, because we think it's really important that we're able to tell that story collectively.
Thank you. I do not see any questions yet in the chat. Again, if you don't know how to use that, folks, there's a little chat icon at the bottom of your screen.
Robin, we did get one a bit earlier from Erica Vaughn. If time permits, a question for Amanda about the scope and considerations for their draft evaluation policy.
Thanks, Josh. Amanda?
Amanda, you're on mute.
Good, you can see me talking. Thanks. Okay, so it's basically what we did was take a lot of what was in the OMB guidance for evaluation competencies and practices, best practices, and we turned that into, and we actually looked at all of the evaluation policies that we have at HHS and several outside of HHS, and we pretty much thought we didn't need to change a lot, but we did make some things that were contextual to HHS, and we're still in development, so it's still technically, well, very technically in draft, and we will clear it later this year.
Okay, here's a question from Rebecca Haas. Are there ways we can leverage some of the resources from GIPRA in the evaluation process across HHS and optives, staptives, but without the dreaded concerns for the old part stick component? That's probably for Amanda.
I think it's probably, yes, for both Ajay and Amanda and me. So yeah, I think the nice opportunity about the Evidence Act is that it is really about learning and using evidence for decision making. It's not about telling people that their evaluation or performance results were good or bad, if that makes sense. And I think that's what you mean by the stick component of the old part. I think, you know, what I and what we in ASPE and HHS tried to really focus on is the opportunity for learning and improvement, as opposed to sort of a thumbs up, thumbs down, this did work or didn't work. As Ajay was very eloquently, you know, saying at NIH, that the whole point of doing evaluations is to understand how things work and what didn't work so that we can improve, not sort of say, you know, that didn't work. So I hope that answers at least some of the questions, or that question.
Yes, thank you. Ajay, do you want to respond to this?
Yeah, sure. So I actually deal with GIPRA a lot as well, in addition to evaluation. And I think, again, with GIPRA, the intent was there, right? But when it was implemented, as you mentioned with PART, it became more of this punitive, audited kind of mindset. And that was a little detrimental. And so when you say how we can leverage GIPRA, one of the things I think is we can learn from that. And it is exactly what Amanda said. We have to reframe the discussion for folks. This is not meant to be punitive. This is not meant to take away your funding. This is meant to understand how things are working. And in GIPRA, I will say in the last few years, we've really made a concerted effort to pivot from this idea of yes, good, down, bad, you know, more like come up with performance measures that are meaningful to you. And that's allowed us to actually engage with the offices in a much more productive way. So I can say within NIH, that trust building exercise that we've gone through for the last 3 or 4 years with GIPRA, we are definitely leveraging to the hilt for moving forward an evaluation mindset and culture.
Thank you so much. The next question is from Jeff Alexander. A lot of the outcome evaluation will require linking data across HHS. How difficult is it to break down those data silos, and how long might that take?
That's a great question, Jeff. Thank you for asking that. There are a lot of data silos, and we are working towards understanding how to break those down. Our Chief Data Officer sits in and will, well, is currently the CIO, but will eventually sit in the CIO's office. Those are both technical challenges as well as policy challenges. Data sharing is very challenging, and we are really working to understand how we can actually make data sharing easier. the way I like to think of making our data open, we in HHS, as Ajay mentioned, are very good about making a tremendous amount of our data open. We don't make it all open because it can't all be open, but we are on a journey, I think, to actually be able to make our data open by default. But that takes a lot of shifting, and it takes a lot of planning to understand what you need to do when you collect the data as opposed to when you've already collected it. There are a lot of thoughts and considerations that go into that. So both for data sharing and data linking, I can't tell you how long it might take, but I can tell you that we are thinking about it, and we are trying to make things easier, especially for data sharing.
Thank you, Amanda. The next question is from Madeline Wallace. What opportunities exist for evaluators' contracts to help HHS in this endeavor?
I think that this is probably for both Ajay and me. And I think, Madeline, what you meant to say is what opportunities exist for evaluators' contractors to help HHS in this endeavor. And I think that, looking at FedBizOps as we move through this seems to be a really good idea. I can't really speak to that. I think beyond just knowing that we do use contractors for a lot of our evaluation work in different parts of HHS.
Yep, and I'll just echo what Amanda said, that in terms of evaluators and sort of the contracting opportunities, it's pockets, right? Some places have already, federal employees who are really well versed in evaluation, and they're able to do that, but it's bandwidth. A lot of folks don't. And so, having good contractors from the private sector who can help them, adapt evaluative thinking and implement evaluations, I think is going to be a critical component, as we move forward as an agency.
Thank you. The next question was from Lori Barker about whether the CDO will be in the Office of the CIO at HHS. The answer is yes. And whether every optive will have a chief data officer. That's up to the optive. Some of them do and some of them don't, unless Amanda knows something differently than that. But I think it's a case-by-case decision.
It is. The requirement is that the department have a chief data officer, not every part of HHS.
Next question from Heidi Al-Shabrari. Hope I'm pronouncing that correctly. Will the developed learning agendas be office specific or all encompassing at HHS?
So as I mentioned, we sort of see the evidence plans as being the whole is the sum of its parts. So for instance, we in ASPE don't really want to tell CMS what their priority questions should be. We want CMS to tell us. So we provided a lot of instruction and guidance for how to develop an evidence building plan and what we were looking for. So we are going to have evidence building plans and evaluation plans that represent the different parts of HHS, but we will put them in one document.
Next from Martha Engstrom, following up on the previous question, opportunities, how can HHS evaluators be involved? And I'm taking that to mean that there's a lot of people already doing evaluation. How can they hook into this effort?
That's a great question, and you should definitely work with your evaluation office at whatever your operating or staff division is. And if you don't know where that is or who that is, you can definitely contact me. I can help you with that. Yeah.
Next question from Eileen Chappelle. Will the required evaluation plans and evidence building plans go through a review or approval process to ensure quality?
Yes.
Thank you. Next question from Yolanda Kennedy Edwards. Would you mind sharing the presentations from today with the distribution list as a reference? So that's a question for Ajay and Amanda. Are you okay with sending out the slides after this?
Yes.
Yes.
I will send you a PDF, Josh.
Wonderful. Do you think that the Evidence Act implementation will change, improve how you communicate with Congress at public legislative hearings, budget, or other committees regarding program impacts and outcomes? And that's from Alexandra Ritchie.
I hope so. Because we are large, we have different functions for how to communicate with Congress, but we do, especially through legislative hearings. So for instance, I would not be a person who talks to or communicates with Congress, but our Office of Legislation would. So hopefully the intent is that we actually have improved outcomes and transparent priorities so that Congress can ask, and anyone can ask, what our priorities are and how what data and what methods we are using to answer our priority question.
Thank you. The next question is from Jonathan Pearson. What will be required of HHS optives and staff divs as part of the Evidence Act versus the Office of the Secretary level? How can optives and staff divs get a head start aside from replying to the capacity assessment survey that you mentioned earlier, Amanda?
Sure. So we're doing the same requirements in the OS that you are. We are developing the evidence building plan and the evaluation plan. We are filling out the capacity assessment instrument, and we're also putting everything together into one document. What you can do to get a head start is to work with your evaluation office at your operating or staff division. And if you don't know who you should be working with, again, I'm happy to help you figure who that might be. Figure out who that might be. Operating or staff division.
Thank you so much. The next question is from Nasifa Buford. Do you think the Evidence Act implementation will lead to new evaluation requirements for cooperative agreements and grant funding?
I don't know. I think it depends on the operating or staff division. And I think the nice thing about the Evidence Act is that it does require us to be both more transparent and more question driven, so that you can see in the evidence building plans and the evaluation plans what we actually are prioritizing on. Yeah.
Thank you. And the next question is from Megan Armstrong. How do you think this act will go on affect state governments?
Well, I mean, I'm not sure. I think a lot of what we do at HHS actually is working with states. We give states a lot of support for a lot of different types of priorities. And I think states are going to, like everyone else, be able to see where we're prioritizing our efforts. Doesn't mean we are stopping any other efforts. It just means that we are prioritizing. And so I think that it will allow states to have a better understanding of kind of what rises to the top and where they might be able to focus their efforts as well.
So just to clarify, Megan sent in, her question is, will states begin to adopt the same types of Evidence Act policies? Is there any move afoot in the states to do a state level Evidence Act?
I have not heard of any moves afoot to do anything similar, but there may be other people out there who have.
Thank you. We are at time and we actually have no more questions. So I want to thank our speakers and thank the TIG for organizing this, and just remind people that this is being recorded. You will have access to it later, that you can listen to it again or share with colleagues, and we'll get the slides out to you. Josh, do you have any final comments that you would like to add to this?
No, just thanks to our speakers. A very informative, excellent webinar, one of the best I've seen in a while, and I've seen a lot in these days. So thank you very much for joining us today, and have a good day, everyone.
Yes, thank you. Bye.
Thank you.